Welcome everyone. I'm going to talk about the role of CT imaging in predicting acute pancreatitis severity and diagnosis of splanchnic vein thrombosis. So my name is Borbély Ruben. I'm a PhD student at CTM and also a radiology resident at Bajcsy-Zsilinszky Hospital. So my vision is that imaging is essential in acute pancreatitis care, and the mission is to enhance the diagnostic and prognostic value of CT imaging. So I have 3 projects in this PhD program, and I'm going to present them. Let's start with the first one. So the risk of developing splanchnic vein thrombosis in acute pancreatitis increases 3 days after symptom onset. So splanchnic vein thrombosis, or SVT for short, is a thrombotic state of the veins of the GI system. Specifically, the portal, mesenteric, and splenic veins are affected. It has wide-ranging etiologies, but in acute pancreatitis, it is a local complication. It is caused by the release of pancreatic enzymes, inflammation, and mass effect leading to stasis, hypercoagulability, and endothelial injury. These are the factors of the Virchow triad for thrombus formation. Diagnosis is based on imaging, as symptoms are aspecific, and it can lead to further complications like GI bleeding, mesenterial ischemia, and it is linked to a higher mortality. So the notable gap in literature is regarding the developmental dynamics of SVT, and we wanted to address this gap. So the question was if there is a difference in SVT prevalence, if you look at the timing of the diagnosis to detect SVT. And we also looked at important AP disease characteristics, if they are risk factors. And the hypothesis was that there is a natural course to SVT development. Using a systematic search and citation chasing, we have identified 15 studies in total. So these are the results. I'm going to show forest plots. The results are in proportion, a number from 0 to 1. On this forest plot, you can see a timing subgroup analysis. In the first group, on the 0 to 3 days after symptom onset, prevalence proportion is low, 6%, but it increases to 23% after 3 days in the 3 to 11 days group. When we look at SVT proportion in the hospital admission day group, it is already 12%. This may be due to patients delaying seeking medical attention. We have done a subgroup analysis for AP disease etiology, and we have found that alcohol-induced acute pancreatitis patients had the highest proportion, nearly 1 in 3. Contrasting this, biliary etiology patients had only 12%. Another subgroup analysis for pancreatic necrosis, we have found dose-dependent relationship between necrosis and the SVT proportions. The strengths of our analysis are that it is the first study to focus on developmental dynamics. Limitations include that most of the studies were retrospective in design, and patients' numbers were low, so that led to some imprecision. So in conclusion, there is a natural course to SVT development with a marked increase in the number of cases after 3 days of symptom onset. There are risk factors associated with it. Implications for practice include that anticoagulation is essential in AP patients, and screening for SVT should be a routine, especially in high-risk patients. Questions for research include, can SVT be prevented, and what is the optimal anticoagulation agent and strategy? So this paper was published in the United European Gastroenterology Journal, and let's continue with the second project. It is titled Improving Severity Prediction in Acute Pancreatitis Using CT-Derived Body Composition Metrics. So in about a decade, majority of the adult population is projected to be overweight worldwide. And we know that excess fat and a high BMI is correlated with increased mortality and complications in many diseases. And visceral adipose tissue may be the underlying factor because it produces many inflammatory mediators. And our aim in this project was to examine the relationship of CT calculated body composition and AP severity. It is going to be a diagnostic question, so we use the PEERT framework. Population is patients from the Goulash trial with a CT scan on admission. The index test is the CT composition matrix. The reference is the actual clinical course of the patients, and the diagnosis of interests are severity, mortality, and complication rate. So the hypothesis is that an abnormal CT body composition can predict these outcomes. Clinical and research implication is that severity predicting algorithms would become more accurate by employing these metrics. So the actual metrics that we use are grouped in this table. We use area-based measurements, volumes, radio density, indexes, and volume ratios. We have preliminary results from 359 patients. Out of these, 29 were severe, and we looked at severity prediction. So you can see the results in this table. We calculated the AUC values of the ROC curves, and I've highlighted the metrics related to visceral adipose tissue in green and fat to muscle volume ratios in yellow. You can see that these are the most accurate. So body composition metrics show good prognostic potential in acute pancreatitis patients, and based on preliminary data, the visceral adipose tissue metrics and high adipose tissue to muscle volume ratios are the most accurate. And furthermore, indexes and volume ratios were more accurate predictors than simple area-based measurements. So in summary, these projects are included in my PhD study. The first one was published in January, and the second project is going to be submitted this year, hopefully. I'm also involved in a third project, which looks at the importance of splanchnic vein thrombosis in the context of pancreatic diseases. Thanks to this PhD program, I had the opportunity to attend many international and Hungarian conferences, and I also have a TDK student, Brian, who is very motivated. So I'm going to finish the presentation with a quote from Nelson Mandela: "It always seems impossible until it's done." Thank you for the attention.
Thank you very much. Another very nice presentation. Can we go back to your first studies, research indication slide? Here, you say that implications for research, so SVT prevention. So how would you design this? How would you proceed on this? I mean, you already have some related plans anyway, but how? This is not an easy question, I think. I mean
yes, this is a hard question. So based on this research, we found out that timing is a factor in development of SVT, so that can be used in designing in further study. So the way I will look at, I would screen for SVT in high-risk patients and register the onset of symptom in every case, because we had much more articles, actually around 80 or 90, that did not register this symptom onset or the timing of CT scan relative to admission. And these data could not be used for this analysis. So in a trial, I would definitely use these timings and register them. After screening, obviously, we would have to make two groups. One receives anticoagulation, the other doesn't, and look at SVT proportions in those groups if there is a difference. Actually, AP patients need anticoagulation due to the in-hospital stay being a risk for thromboembolism anyway. The question is, are mild patients affected? And those patients that are sent home, do they develop SVT later on? So this would be an expensive trial to run and a complicated one.
So my question is actually related to this one. So for the first one, you mean the anticoagulation in prophylactic manner, like without the evidence of thrombosis?
Yes. For in-hospital acute patients, general guidelines do recommend anticoagulation. We do have data from randomized trials that heparin can improve survival in acute pancreatitis patients. So I would say that it is essential to give them anticoagulants.
And my second question would be, did you also look for the prevalence of thrombosis in specific splanchnic veins?
Yes. So the splanchnic vein was the most affected. So this can be due to the dominance of local factors in acute pancreatitis. So the inflammation near the pancreas and the necrosis plays a huge role in the development. So this splanchnic vein was the most affected, and mesenteric and portal veins less often thrombosed. In contrast, when SVT develops in cirrhosis, the portal vein is the most often thrombosed. So we see a difference there.
Thank you.
My question is about your second topic. You showed a slide with the different AUC values for the different types of measurement. Yeah, this one. So my first question is, how did you come up with these different indices? And second question is, why not just put everything into a single model and maybe get an even better AUC?
Mm-hmm. Thank you. So these metrics, regarding your first question, these metrics, some of them were already in use in literature. So the area-based measurements were the first of these types, simply just measuring an area of fat, muscle, and the type of fat in an abdominal slice was proven to be enough to predict body composition. But later on, data came out that there are more advanced metrics that are even better. And like the density of the skeletal muscle was shown to be a good predictor. So infiltration of the muscle by fat is a degeneration of the muscle tissue. And that was proven to be a predictor in other contexts. But to normalize for patient height, some articles divided these metrics by the square of the patient height, similarly to BMI. The new metrics we have developed are the volume-based measurements, so measuring the whole abdominal volume and calculating how much of that is fat is new. And we have also created the volume-based indexes where we divide this volume by the cube of the patient height. Additionally, the volume ratios have been developed. Area-based ratios have been in use already, but we use the volume ratios, these in hope that they are more accurate. And so basically we looked at all of these metrics to calculate an AUC. Just in the preliminary analysis, we do plan, if we can, to make a model out of these metrics. The hard thing to do is to look at confounders in the patients. So body composition has an evaluation throughout the life of a person, and we have to look at data if we are not predicting only that older people have more visceral adipose tissue and they have more severe disease because of the confounding comorbidities. So we will look at those confounders. These are just preliminary results.
Interesting talk, especially for surgeons. So we often see in our clinical situation patients with portal venous thrombosis or splenic vein thrombosis. So what is your thoughts about the impact of thrombosis in the venous system in terms of patient prognosis? Do you think it's important because we are losing patients suffering from acute pancreatitis to septic complications? What is your idea and your thoughts about the impact on this kind of thrombosis?
Thank you for the question. It is emerging that splanchnic vein thrombosis is independently predictive of some complications, including the gastrointestinal bleeding. So patients, due to the thrombosis in the portal vein, develop hypertension and collaterals form, gastroesophageal mainly. Those can lead to potentially life-threatening bleeding. And additionally, colonic and bowel ischemia can develop due to the stasis of the venous circulation in the bowel. It has been shown that this usually appears 2 weeks later relative to the thrombosis. So first patients develop thrombosis, then bowel ischemia, and that is also potentially fatal.
Good point. Another question, I have time? Yeah, okay. Sure. So we're talking about volume in abdominal volume and things like that, and your ratio. And do you think there's an influence by intra-abdominal pressure on the perfusion and the maybe one of the risk factor for developing thrombosis?
There have been some studies published on this topic that the intra-abdominal pressure is a factor in developing thrombosis. In regards to the body composition and intra-abdominal pressure, specifically in AP, I haven't found any studies, but we could hypothesize that higher content of abdominal fat leads to higher pressure, leads to thrombosis and worse outcomes.
Thanks.
I have one more question regarding to this first project that you mentioned that the highest proportion of the SVT is in the alcoholic-induced acute pancreatitis. And what can be your explanation about this?
Thank you. So alcohol has been shown to influence the coagulation, and specifically high doses of alcohol consumption has been linked to thrombosis, while low amounts of alcohol can be even anticoagulants. But in patients with AP who develop AP due to the alcohol usually consume alcohol in high doses. So this can be one explanation for that.
Thank you.
So here we can see these AUC values. how one can interpret these values. So what does it mean that an AUC value is 0.617 or whatever?
So these AUC values are a measure of how predictive a metric is, and we look at them in a chart when sensitivity and when minus specificity is looked at a continuous or a whole range of cutoffs, and we summarize the area. And when this area is 1, it is a perfect predictor. When it's 0.5, it's a bad one, so it's up to chance. So these values are between 0.5 and 0.7, which is a somewhat good predictor.
Do you know by any chance that they have, or it has some probabilistic interpretation? So it is the probability of something. Do you know that the probability of what?
Well, it does relate to the probability of the matrix values not overlapping in the
something
populations.
Like that. Yeah, exactly. And for your first study, have you thought about publication bias? And if yes, how did you measure or how did you assess that?
Yes, we have looked at it. So we made the funnel plots for each of the outcomes and looked at asymmetry and I've looked at the p-values of the Eggers test and we found no publication bias, luckily.
Thank you for the really great presentation, and I've got a question for your second project. So it's only that how do you calculate the index type metrics?
So the index is, we divide the area-based measurements, so these are in square centimeters. We divide them by the patient height, which is in meters squared. And for the volumes, we divide by the cube of the patient height. And these were more accurate than just using the area or volume simply, just as looking at BMI is more accurate usually than just the weight of the patient.
Great talk. I just have a quick question. I noticed that you did subgroup analysis for your first topic based on the percentage of necrosis in the pancreas. So it's like the radiological severity grading, let's say. Did you have enough data, or did you think to do the same subgroup but for the clinical severity type, like mild, moderate, and severe acute pancreatitis, and to see how the proportions of the SVT changed, if there's more in one or the other?
Yes, thank you. So we did look at it. Usually studies report that more frequently. I haven't brought the data because of the lack of time to present, but there was an increasing proportion by severity, but it was not significant. So there were huge overlaps between the groups.
Okay, thank you. So it's a question again about your second topic. So did you consider doing some kind of end-to-end deep learning type of model to predict AP?
Yes, so I would look at neural networks first, because we have so many clinical data points and all these types of metrics, and we could put all these data into a neural network and have a prediction of severity. I think the body composition prediction will be more widespread in a couple of years, because it became easy to do these body composition calculations recently. So the UNet network was developed, and we have more powerful graphics cards that can do this type of analysis, and I think in maybe 5 or 10 years it will be standard.
Do we have any data about the preventive effect of anticoagulants in vein thrombosis, splenic vein thrombosis in acute pancreatitis? You said that the recommendation would say that every case should be anticoagulated, but I believe that it is not the regular practice, especially for mild. Most of the cases are mild acute pancreatitis. We are not giving anticoagulant them routinely. I'm wondering whether your studies, did you find any difference between those patients who were receiving anticoagulants and who were not? Do you have any data about that?
Thank you for the question. Not directly in these articles, but when writing the discussion, I came across studies that do report a lower SVT prevalence in those patients that are anticoagulated. Some of them limit this to only necrotizing AP patients, but even in the general AP population, there is a reduction. Regarding severity, I've mentioned for a previous question, mild patients had 10% prevalence of SVT in our analysis. So that I would say is substantial in practice. Every 10th patient who is mild develops it.
I think there is a substantial bias in those data. We are not seeing that many patients in mild acute pancreatitis, 10%. Obviously, we are not examining them, all of them with CT or CT angiography, which would be the more exact way to do that, but there are no clinical signs of any thromboembolic events in most of the mild acute pancreatitis cases. So this 10%, I would say that it is an overestimation based on publication bias or so.
We only included studies that have done CT on all of the patients, not only on those who were symptomatic, but everyone. So and additionally, it has been shown that these type of thromboses sometimes do resolve on their own, even without anticoagulation, in the high 60-80% range. It has been reported that it is resolving on its own. So obviously we don't know for sure, but
a nice question came across. What do you think? We always in discussion if we have a patient with acute pancreatitis between gastroenterologists and surgeons, and how to treat and how to take care. And what do you think? We have one possibility as a surgeon to treat and to avoid mesenteric veins thrombosis by inserting a catheter into one of the small mesenteric vein to introduce heparin directly before the thrombus. What do you think? Is this more? It's too aggressive, or we can use it in special cases, or what are your thoughts about the situation if we discuss this? And I'm saying, we have to reduce a catheter, and my colleague saying, no, don't do this, it's too traumatic. And what's your idea about this? You can say everything.
Yes, that is interesting. So I would say it would be useful because in AP we know that local factors have a huge role, and targeting that specific area with anticoagulants would be more effective, I would say. So there might be a future for this.